Good afternoon. Thank you for taking the time to join us for this presentation. My name is Tanya Gottlieb, and I'm the Vice President of Scientific Affairs at MeMed, a company developing new tools based on the host response to address clinical dilemmas. I'll be moderating today's presentation. Before we get started, I have a few quick housekeeping items. The webinar interface is completely customizable, and you can resize or move any of the modules to get the most out of your interface. We will be answering questions through the Ask a Question module. All questions will be anonymously directed to me and won't be visible to the group. We'll answer logistical questions throughout the webinar. Questions for the speaker will be answered at the end of the presentation, and anything we can't get to we'll answer via email. Lastly, if you're attending with a group of people on the same line, please, through the Q&A, let us know how many people are in your group, as it will help us with gauging attendance. With the housekeeping out of the way, I'm very pleased to introduce our speaker. Dr. Adi Klein is Chief of Pediatrics at Hillel Yaffe Medical Center since 2007. She's head of the Israeli Clinical Pediatric Society and associate professor at the Technion Israel Institute of Technology. Dr. Klein works in a medical center with a pediatric emergency department that treats over 25,000 patients a year and is specialized in emergency medicine. For several years, Dr. Klein has led the residency program and overseen the training of hundreds of doctors, some of whom are now chiefs of departments across the country. She has volunteered in humanitarian missions in Nepal and is a treatment coordinator with neglected and abused children. Thank you, Dr. Klein, for taking the time today to talk about using MeMed BV for differentiating between bacterial and viral infection, and for sharing your real-world best practices, case studies, and insights.
Thank you, Tanya, for the introduction. I'm delighted to be here and share my experience. Before I begin, I would like to mention that I have nothing to disclose. I'd like to start by considering the challenge. The best way for me to do this is to describe a case study. This is an example of a child that presented to the emergency room at Hillel Yaffe Medical Center. It was a previously healthy 2-year-old male with 3 days of fever, with cough and runny nose. Vital signs were 100.4 Fahrenheit, 136 beats per minute, and sats at 97 in room air. His physical exam, he was well-appearing, interactive, no acute distress, scattered wheezing and slightly liquid breath sounds on the left side on auscultation to his lungs, and he had an erythematous throat without any exudate. On his laboratory exams, he had 12,000 white blood cells with left shift and CRP 95.7. On chest X-ray, we saw bilateral interstitial infiltrates versus atelectasis with the remark of correlating clinically, as it usually is. As pediatric emergency medicine clinicians, we are familiar with this type of case. It's a classical case with diagnostic uncertainty. A decision needs to be made. On one hand, we do not want to give antibiotics if they are not warranted, as we know they can cause side effects and contribute to on a large scale to antibiotic resistance. On the other hand, we never want to be faced with the realization that we sent home a child with an untreated bacterial infection, who later deteriorates and has complications. What would you do? One option is to do additional testing. You could take a nasopharyngeal swab to find out what viruses are present. However, we all know that detection of virus does not rule out bacterial co-infection. Another option is to treat empirically with antibiotics. but we all know that up to 40% of patients with viral infections are prescribed antibiotics and overuse that we are trying to combat. Now, there's another option, a blood test based on immune response to infections. It's called MeMed BV. Test result is a score that integrates the level of three biomarkers: tumor necrosis factor-related apoptotic inducing ligand, TRAIL, interferon gamma-induced protein 10, IP10, and C-reactive protein, the CRP. Higher scores, 65 to 100, are indicative of a bacterial immune response, and lower scores, 0 to 35, of a viral immune response. You're all wondering what was the BV test result for this child. Well, it was score 6, which is highly indicative of a viral infection. Let me explain in a little more detail how the BV test results are interpreted. As I mentioned, the result is a score between 0 and 100. Interpretation of a score result is that scores under 35 are indicative of viral infection or other non-bacterial etiology, with scores between 0 and 10 highly indicative of viral infection. Scores over 65 are indicative of bacterial infection or co-infection, with scores between 90 and 100 highly indicative of bacterial infection. Scores between 35 and 65 are equivocal, meaning that the result is valid, but the BV test is not providing etiological information. Importantly, 90% of patients get bacterial or viral scores, and less than 10% get equivocal score. I will present you a case study to highlight the clinical challenge that the BV test helps to address. Enhancing my ability to provide excellent healthcare to my patients is the main driving force for me to seek out and adopt new technologies. Beyond that, I'm a strong believer in innovation, and especially in disruptive technologies, as the way to improve patient outcomes. Using new tests based on the host response to manage patients with acute infection is the next frontier in infection disease. The host response gives information on the interaction between the pathogen and the patient that overcome limitation of pathogen detection testing. At the most basic level, pathogen testing requires sample access to isolate the microbe, which is not always possible, especially in lower respiratory tract infections. As the immune response circulates in the blood, it can be detected with a simple blood test. As I mentioned when describing the case study, detecting an organism does not mean it is causing the disease. In contrast, the immune response is triggered by the disease causing the microbe and not by the carriage or colonization. This is why the immune-based test is revealing the pathogen and it's actionable. Listening to me, you might be thinking that conceptually a new immune response technology seems like a good idea, but how would you ever be able to trust the result of this new test? Well, I agree. It will take time and experience with using this test to really understand its strengths and weaknesses, and learn when to incorporate the new test into the diagnostic processes. But already today, the sensitivity and specificity of BV of over 90% has been validated in multiple clinical studies performed across the world in children and adults. The test has been run for over 20,000 patients in over 30 medical centers all over the world. As the test is implemented in my department, I'm seeing how it provides added value over the tools that you are all familiar with. The BV test has higher diagnostic accuracy than white blood cells count or absolute neutrophil counts. The data you see here are from the Curiosity study that enrolled over 1,000 of children and adults, and for which I was a PI. When compared to CRP, procalcitonin, BV shows higher sensitivity and specificity. But more than that, the BV score has been shown to be accurate also when children present early after symptom onset. This is a known blind spot for the CRP that typically takes 48 to 72 hours to rise in response to a bacterial infection. Another added value of BV that really has meaning for me and for clinicians all over is that when there is a co-infection, both viral infection and infection plus a bacterial infection, the BV score result is bacterial, which is this helps us to make sure that the clinicians can be defined that the viral score can be trusted to rule out bacterial infection and co-infections. The data in this slide are from a sub-analysis of the Apollo study, which I mentioned which I will mention in a moment. In the graph, every dot is a patient. The x-axis shows the patients with bacteria versus viral reference standards, and the y-axis is the BV score. Focusing on the 177 patients with respiratory tract infection and a viral detection, you can see that the bacterial infection patients get a bacterial score. That this finding is true also for patients with adenoviral detection, as described in the next slide, is a significant added value over CRP. Another added value of BV is with adenovirus infection. Adenovirus is one of the major pathogens causing acute pediatric respiratory illness that often mimics bacterial infections, making it challenging to differentiate adenoviral infection from adenoviral with bacterial co-infection. In a sub-study led by me that enrolled from Curiosity and Opportunity studies, out of 127 cases with adenoviral detection, there were no cases classified by the adjudication-based reference standards as having bacterial infection for which BV yield a viral score, which means no false negatives. BV can help us to rule out bacterial co-infection in children with adenoviral detection. The Apollo study was designed in alignment with the FDA to support regulatory clearance for the BV test. I was one of the clinical PIs among a team that included Dr. Richard Bacher from Boston Children's and Dr. Shelley Kaplan from Texas Children's. The study validated the high accuracy of the BV test in children and adults presenting to the emergency room and to urgent care centers, and using the rapid measurement platform called Key, which we have installed now in Hillel Yaffe. I'll show you a picture in a few slides, but let me first give you some information about Hillel Yaffe Medical Center. Hillel Yaffe Medical Center is owned by the government in Israel and located in Hadera. It serves a population of 600,000 residents, of whom 150,000 are children. It is a diverse population from cities and rural settings covering socioeconomic range. The Hillel Yaffe Pediatric Division consists of a pediatric emergency room that treats 25,000 children each year. The pediatric department has 31 beds. We have 8 pediatric attending physicians and 22 residents, and a lot of interns and students as well. Implementation of the measurement platform MeMed Key, seen here in the photo, and of the BV test has involved alignment between multiple stakeholders and the hospital, including myself, the hospital administration, and the laboratory team. The MeMed team have been very supportive of this process, as we all appreciate that it is not easy to introduce a disruptive technology into healthcare. To help clinicians understand the test and learn to trust its utility, MeMed MSLs have conducted training sessions, one-on-one meetings, and periodic case study discussions. Also in the lab, there have been training sessions. The test is now included on the list of tests available within the electronic order system, and the results come through the hospital information system. There were some challenges in getting this set up, especially in the placement location for the key device, but now we have 24/7 availability, as you can see on the next slide. Here I'm showing you that the BV tests are ordered across the day. Not surprising, the largest portion of the tests, 45.4, are ordered in the afternoon and evening, which is the busiest time in the emergency room. Then a third are ordered in the morning and the rest during nighttime. Once we got the BV test up and running as part of routine care, it became clear that we needed to consider carefully on which children it should be applied. It is a guiding principle for all clinicians that there is no point ordering tests if the results will not impact on your practice. So I've thought deeply about this. According to the regulatory cleared intended use, the test can be applied to any febrile child over the age of 3 months when there is a suspicion of bacterial versus viral infection and symptoms have been experienced for less than 7 days. However, in my eyes, children presenting to the emergency room can be classified broadly into 3 groups. Children with fever that arrive to the emergency room are divided to those that are well appearing and or have clinical, who can be easily clinically diagnosed by physical exam and don't need any more workup. Those children we can discharge or treat without using the MeMed key. The other group is those that are severely ill or are presented with an obvious bacterial or serious infection, which will be treated immediately, and there will be no use of the MeMed key. The third group and the largest group are those that arrive with fever, but we don't have clinical diagnosis whether it's a viral or bacterial infection, and we need more exams to further diagnose them. Those are the children where BV score will help us treat them. We have not yet got ethical approval to analyze the over 2,000 children who have had the BV test run as part of their routine care. An IRB application is under review. However, we can take a look at the distribution of test results across the score bins. As you can see, roughly 60% of the children get high likelihood scores, with only 30% of cases getting equivocal scores. And around 70% of the children get viral scores below 35, which is what you would expect for a pediatric emergency room. Now, in the last part of my presentation, I thought it would be helpful to look at a few cases where the BV score impacted patient management to give you an insight on its adoption in routine care. Please note, these cases have been de-identified to protect patient confidentiality. I'll start with the presentation of the first case. An 8-month-old male with fever. He was born full-term, no past medical history, immunization up to date, and he had 4 days of fever, maximum temperature of 104, productive cough, decreased appetite, slight rhinorrhea, no vomiting, no diarrhea. On physical exam, he had temperature, as I mentioned, 104 degrees, heart rate of 166, respiratory rate 27, blood pressure 106/62, sat with 91% on room air. He was alert, no acute distress. His ear examination had showed normal tympanic membranes. On his oropharynx examination, moist mucous membranes and throat erythema with no exudates. On pulmonary auscultation, there were equal breath sounds bilaterally, with wheezing noted on the right lower lobe. Abdomen and heart had no physical signs, and on his skin there was no rash. Medical history and physical exam directing us towards viral infection, but because of the prolonged fever, laboratory exams were taken. White blood count was 18.5, absolute neutrophil count 7.7, CRP was 60, which is elevated, platelets 374, urinalysis was normal, and the child was sent for a chest X-ray that showed hyperinflation with peribronchial thickening with opacification in the right lower lobe, infiltrate versus atelectasis with correlation to clinical course. Blood culture was sent. This case presents uncertainty whether this child had viral bronchiolitis or he had a secondary bacterial infection, which was illustrated in the chest X-ray and the elevated CRP. So we took our MeMed BV score, and it was 4, which means a high likelihood of viral infection, which makes us more confident in treating this child as viral-induced wheezing or bronchiolitis and not treating him with antibiotics. The child was treated with albuterol administered with good response in the emergency department, but he was admitted to the pediatric floor for supplemental oxygen and albuterol as needed. The next day, clinically improved with improved saturation, and he was discharged home with a viral-induced wheezing diagnosis, and his blood cultures came negative. The summary of this case presents a patient that appeared to be viral but could not definitely exclude the bacterial component because of his age, duration of fever, and chest X-ray findings and elevated CRP. The MeMed BV viral score of 4 supports viral infection and provides the physician the confidence to treat the patient without unnecessary antibiotics. Now I'll present the second case. An 18-month-old female with fever. She was born full term, no past medical history, immunization up to date. She had 2 days history of fever up to 103, rhinorrhea and cough, vomiting 3 times a day, non-bilious and non-bloody, and no diarrhea. On physical exam, she had heart rate of 165, temperature 103, blood pressure 107/66, respiratory rate 30, and sat on room air 96. She had no acute distress, mild dehydration. On her ear exam, she had normal tympanic membranes. Oropharynx showed dry mucous membranes with slight throat erythema. Her eyes had erythematose, were erythematose and teary, no discharge. On pulmonary auscultation, she had slightly decreased breath sounds bilaterally. Her abdomen was soft, non-tender, no hepatosplenomegaly, and no rash. This child presented with a viral respiratory tract infection, but because of the decreased breath sounds on her lung auscultation, we had additional tests. She had white blood count of 8.1, actual neutrophil count 3.8, CRP 46. Blood culture was sent, and chest X-ray showed bilateral peribronchial thickening and no infiltrate. Nasopharyngeal PCR for viral pathogens was sent. This child presented with a clinical and laboratory viral infection, and he was supposed to be sent home after rehydration because of the somewhat dehydration that he presented with. But we sent a BV score, and we got a result of 93. 93 is a high likelihood of bacterial infection in this child, which in our hospital made us think a little further about this child and admitted him for further examination on the next day. As I mentioned, this child presented with mild dehydration, and she didn't tolerate oral fluids in the ED. Nasopharyngeal PCR showed human metapneumovirus that could explain the whole course of her disease. He was admitted for further observation with working diagnosis of viral illness, but taking in concern our BV score. The next day, patient vomiting resolved, but fever ongoing, and on lung examination, there were significant freckles on the right side. And that was the place where we diagnosed her with having a secondary bacterial infection and started treatment with antibiotics. To summarize this case, the MeMed BV bacterial score preceded the clinical diagnosis of bacterial pneumonia. Viral respiratory tract infection, in this case human metapneumovirus, can be complicated by bacterial pneumonia, and this child could be sent home without antibiotic treatment, and the MeMed BV was a useful tool for detection of bacterial co-infection.
Thank you, Dr. Klein, for that really interesting and informative webinar. I think we can now take questions from the audience. So I'm going to read out the question, and then Dr. Klein, if you'll be okay to answer it.
Yes, of course.
So, thanks. Okay, so we have a question here. So it's a question about the results interpretation. So the question is, you said that the scores between 65 and 100 are indicative of bacterial infection or co-infection. So the question is, how do you know if it is actually a co-infection?
Well, the score does not inform if it's a bacterial co-infection or just bacterial infection. Only the clinical presentation of a viral infection or viral detection will indicate that there is indeed a viral infection with a co-infection.
Okay, thanks. Great. Okay, so I see that we have another question now. Okay, so the question is, how has the use of the BV test changed your emergency medicine practice?
Well, we are at the beginning of the adoption phase. So realistically, the BV test is impacting practice by helping the clinician to be confident that the bacterial infection is not being missed out when a viral infection is suspected, and gives confidence to withhold antibiotics even when the CRP is elevated or there is leukocytosis. In the future, as we go to know the BV test better and gain experience, we may perform fewer X-rays and fewer admissions to the pediatric ward and fewer pathogen panel, but it will take time until this impact is measurable.
Thank you, Dr. Klein. Okay. And here we have another question. So this is about the different pathogens. So are there any specific pathogens that MeMed BV misses, or I assume they mean doesn't perform well with that pathogen?
So I don't know if you are aware, but there is a limitation that the test has not been studied in patients with suspicion or confirmed diagnosis of infection, gastroenteritis, colitis. And I think data in this population will get collected over time.
Okay. So this is another question. How did you educate your clinical staff about the use of the test in your hospital?
So at the department meetings and on rounds, I talked with the staff, with the residents, with the steering physicians about their patients, and they use the BV test in the diagnostic process. I think regular discussions about new technologies are critical during the introduction phase to share insights and learning and to build confidence in its value. I'm also keen to expand the knowledge for the wider community. As Tanya can tell you, I'm always brainstorming on analysis of past data and new studies that are needed to expand the use of this powerful tool.
Yes, I can confirm that that's correct. Okay, so I think we've got time for a couple more questions, but if we don't get to all your questions in the webinar, we'll try and answer them, later. But let's see, I think you answered this one, but the question is about the regulatory clearance. Is MeMed BV FDA cleared? That's the question.
Yes, it's available in the U.S., Israel, and Europe.
Okay, that was an easy one. Okay, here, this question is probably a little bit more challenging. So the question is, why was this BV test adoption, a priority for you over other tests? I think they mean, why did you really want to bring this one into your practice? There are various other tests available that people, are trying to recommend to try out. So how come you decided to go with this one?
So as I mentioned, I'm really keen to stop giving antibiotics to children with viral infection, but also never want to miss a bacterial infection. It's the nightmare of every emergency medicine physician. The child that looks well and was sent home with a presumed viral infection will later deteriorate very rapidly due to a bacterial sepsis and become dangerously sick. It is the fear of this nightmare situation that drives us to prescribe antibiotics even when they are fairly confident that the child had a viral infection. The BV test was designed to address exactly this uncertainty. It is not 100% accurate, but it gives another tool. No test is 100% accurate, but it is so much more accurate than anything we have available today to help with this decision.
Okay. So I think this will be the last question, actually. So this one is about the implementation. So the question is, what coordination was required with the laboratory to get the test up and running at Hillel Yaffe?
For implementation to work, there has to be close coordination between the lab and the emergency department clinicians. For the decision of which lab should run the test, for example, the microbiology or immunology lab, to the pathway for the sample tube, to the way that the test appears in the ordering system, and so on and so on. Being one of the early adopters, I took into account that we would likely have to deal with unexpected difficulties and need to be creative in how we found solutions. The work with the laboratory staff what gave us the opportunity to make it happen. And I'd be happy to take this question offline and talk more about it with was the one that presented it. Thank you.
Okay, so thank you, Dr. Klein. So it seems we're at time. So again, if we didn't get to your questions, we'll try and answer them by email. And now a couple of housekeeping matters as we close. It would be great if you could take the time to answer a short 4-question survey that appears if you scroll down. And just to say that this webinar will be available for on-demand viewing and sharing using the same URL. And Dr. Klein, thank you so much for today's presentation. And I wish everyone a great day. Thank you for joining.
Thank you so much for the opportunity. Thank you, Tanya.